Welcome back. Our final talk of the afternoon is a dual talk, and so I have two introductions to share with you. First, I'd like to introduce Danny Keller. So Danny is one of our conference co-chairs. He's an amazing UCSF physical therapist who's a board-certified orthopedic clinical specialist, as well as an associate clinical professor in the UCSF graduate program in physical therapy. Danny is really a fantastic clinician. He's one of those physical therapists where I know that if a patient is seeing him, they're in the best of hands. And when he's not in clinic at our offices at Mission Bay, he's teaching in the DPT program and the PT orthopedic residency program. He's also at Cal Berkeley providing care to the D1 athletes. And he's always busy with impactful projects, including working as one of the therapists in UCSF specialized clinics for patients who have undergone limb amputation and osseointegration. And he's also done research in projects involving the development of exercise programs for NASA astronauts with low back pain. So you can ask him about space later. Like I said, I asked all of the speakers today about their favorite restaurants in the Bay Area. So for Danny, he said it was really tough to choose, but said his favorite place to eat is either Teleferic Barcelona in Walnut Creek, which is a buzzy destination for Spanish pinchos. Am I saying that right? Appetizers, paella and sangria. Yeah. Or Bee Patisserie, which some call, and you may know, pastry heaven here in San Francisco. So Bee Patisserie is a good one. Bee Patisserie, yeah, on California. Can you tell me that first one again? The first one is Teleferic Barcelona and Walnut Creek. They also have some other locations. Thank you. Yeah, you're welcome. All right, so that's Danny. And next is Tim. So Tim Baldwin is an ABC certified fitter of orthotics, a certified orthotic assistant, and a BOC certified athletic trainer. Tim's currently the Clinical Operations and Compliance Officer for UCSF Orthotics and Prosthetics, overseeing all UCSF orthotic and prosthetic clinics. He's worked in a lot of different settings within the Orthotics and Prosthetics Department, including the Orthopedic Institute, the Mount Zion inpatient setting, and various clinics at Redwood Shores and Mission Bay, both inpatient and outpatient. He draws on years of clinical experience to optimize operations and ensure compliance standards are met and exceeded. When I asked Tim about his favorite place to eat in the Bay Area, Tim recommends Twisted Donuts and Coffee, which is a family-owned classic donut place in the Sunset. On weekdays, they have classic donuts, and on weekends, they have crazy donuts. And those crazy donut types include S'mores Galore and Nutty Monkey. So head out to the Sunset District. I'm thrilled Danny and Tim are here today to give the first of their two talks for this conference. Today is on knee and hip, and tomorrow on shoulder, foot, and ankle. We've asked them to pick a few high-impact interventions, whether exercises or bracing, we can provide our patients and athletes in the training room or in the clinic, in this case today for hip and knee problems. So please join me in welcoming Danny and Tim.
Okay, I'll start.
Mine work too.
Ooh, all right. Tim and I are going to dance around a little bit for you guys. We're going to not stand at the podium. If our mics cut out, we'll just yell, I guess. All right, so thanks for having us, guys. This is the first time Tim and I have done this lecture together, so it'll be fun. We have no disclosures to present. All right, so kind of what are we going to go through with this one? Bracing is generally a stepping stone, right? Both Tim and I agree that braces aren't long-term for the majority of patients. What is the focus of bracing? So the focus of bracing is going to be for pain control, stability in a short period of time, muscle assistance, activity tolerance, building confidence, especially post-op, preventative secondary injury, prophylactically. All of these things are what bracing is used for, but you can see a lot of these things are short-term, right? We can also use braces to assist in our exercises to improve efficiency and effectiveness, reduce pain while we're doing exercise. So we'll talk a little bit about that.
Yeah, so basic protocol that we wanted to show here is kind of how you could go from injury to brace to rehab to out of brace. And so a lot of times you'll start with an injury or a complaint. It can be chronic or acute, obviously. They have a reduced activity is usually why they're coming to you, because there's something they can't do. That's why they want to be seen. a lot of times, if first intervention is bracing, especially in acute worlds, and it's because you want to limit things like range of motion. You want to provide stability so that they're not at risk of having further injury. If you have a lower extremity injury, you want to brace them to lock them out so that they're stable, because you don't want them falling and breaking a wrist or getting a concussion, which Dr. Center can tell you about after in other talks. And so that's usually where that first intervention comes in. From there, once they have their diagnosis and or their surgery, they'll go on to physical therapy. And the idea is that brace can either help promote that physical therapy, because if something hurts too much, some braces can maybe reduce that pain so that they can advance in physical therapy more. Or it's to limit range of motions that they're not supposed to do yet. And it gives a good barrier for the PT to know how far to take it, how far not to take it on certain things. And then from there, we try to get back to return to play. And there are some braces that you will use in those return to plays, but most of those we will tell patients at some point you can probably stop using it. Now, there are some long-term patients. OA is probably one of your most perfect examples. Some people never want surgery. So if you're not going to physically correct it, something may be long-term for those purposes, but most of them you're going to tell people to wean out of and or stop using at some point. So hip bracing. There's not a lot of hip bracing. That's one of the things. This is usually for post-operative care in most settings. Or acute injury. So the one you're going to see most often is a hip T-scope. And what that means is it's a telescoping brace that can go up and down the leg to provide as much lever arm as you need. It usually controls either one plane or two. It can either be for flexion extension, but it can also control abduction, adduction. So there are certain braces that we can put special hinges on that can control those things to keep people in a certain position. Pediatrically is the one, if you do any pediatric treatment, that bracing is actually a first intervention and they're in all the time. And that's usually for a hip dysplasia issue. So when it's diagnosed early, it can be, I've fit babies as early as a week and a half old. That they can be put into this, and it's usually because they have a hip socket that isn't fully formed or not perfectly formed. They can't really go to PT. I don't know how much PT you can do with a 1 week old. It's limited. So it's all about positioning for growth. So there are things like a rhino brace and a Pavlik brace that are pediatric specific that are really your first and only intervention for a while, and you're trying to avoid surgery with that. Otherwise, there are some active hip braces out there. One of them is for OA. You have a lot of runners that want this, but essentially it's going to pull you into external rotation to reduce OA in the hip. Studies on this stuff and the efficacy of it is minimal. One, it's not studied a lot. There aren't a lot of great studies on bracing in general. It doesn't have a lot of research behind it. So it's more about what you know, what you've seen, what you fit, what you've done. It can be effective, but again, it's not going to be your long-term solution. You're still going to need another intervention, whether it's strengthening, surgery, or surgery and strengthening, right? But I have had people that say, I've got a marathon in 6 weeks. I just got to get through it. Something like this could be helpful, but it's really hit or miss with this type of stuff.
One thing from a PT standpoint, how many PTs are in the room? Raise your hand if you're PT. What's up, my people? All right, we'll do our handshake later. One thing that's really important from a rehab standpoint that I see a lot, especially in newer PTs, is understanding how to adjust a T-scope, right? We see them consistently, and we're taking them on and off more than anyone else, except for maybe the patient themselves, if they're supposed to or not. So really make sure you understand how to adjust the T-scope and how to make changes to it, because every once in a while you'll see somebody come in and that T-scope has been adjusted very incorrectly, and the patient's talking about how they have pain, it's changing the way they're moving, those types of things. So you need to understand how these work. If you don't know how they work, play with them, get a test one, go talk to somebody who fits them, and help get an understanding for how to fit these correctly, where the pivot point's supposed to be the axis of rotation, how the straps are supposed to be tightened. It's super, super, super important. All right, so hip rehab. So there's about 1 billion exercises that we could go through for hip rehab. I don't want to spend time going through 1,000 exercises. You guys can if you want. But we were just going to talk about some kind of basic ideas behind hip rehab. And then if you guys have questions on specific exercises or specific situations you want exercises for, you can definitely let us know. So post-operatively, how do we use these hip braces? So in general, using these braces, especially things like the T-scopes, help us understand where range of motion limitations are at. So with a lot of these protocols, you heard Dr. Wong talking about kind of keeping that foot flat, hip neutral position after a hamstring repair. understanding where range of motion limitations are is really helpful when the range of motion numbers are on the brace. It also helps your patients to understand it because we might be able to measure in the clinic where 30 degrees of knee flexion is, but they may not understand where that is, right? So we can keep them in the brace when they're doing their exercises like that. And if the protocol is a 0 to 30 range maximum, we can keep that brace set at 30. They can go until it stops, and it allows us to make sure they're doing it safely, effectively, and following that protocol. So this is where one place where braces can be extremely beneficial from a rehab standpoint, right? Weight-bearing exercises in the brace to provide support initially. So as they start to get weight-bearing, you'll see a lot of weakness, apprehension, these types of things when they first start, right? So we want to make sure that these braces are used to help back up that support system, to give them some support both externally and then also mentally, to make them feel more comfortable and confident as they're getting more into weight-bearing activity. From a non-operative standpoint, most of my patients are only in the brace if it's more comfortable for them to do their exercises and more efficient for them to do their exercises. So I really like patients doing exercises out of brace as much as possible. It's not going to make them weaker to do an exercise in a brace, right? I think this is one of the biggest myths that we all hear is if I wear a brace, I'm not going to get stronger. If I don't get stronger, I'm not going to get better. That's not the case. If we're doing exercises that promote strength within the areas that brace is supporting, there's no reason you should get weaker using a brace, right? I've heard people even talk about it with knee sleeves, right? Like if I wear a knee sleeve, I'm going to get weaker. There's nothing about that knee sleeve that's actually going to support your leg, right? So understanding that and using these braces to help supplement exercise is really, really important and the whole purpose of what we're trying to do.
And on to knee. This one has a lot more, so a lot more that you can talk about here. Also, we're going to have a lot of times for questions because usually with DME, we've learned in rehab, you guys want to ask more than you want to be told. So we'll have plenty of time for questions after this. But for knee, there's a ton of options, whether it's acute injury, chronic injury, it's post-operative care. You can take people through a progression of bracing with the knee specifically. So the most common that you're going to see for any knee injury is your T-scope. Now, they talked about earlier, you know, if you're a primary care, you see a patient, they had their weekend warrior, they likely tore their ACL skiing, they're swollen, lack of range of motion, all the normal things you're used to. Most times people will order a knee immobilizer. I call it the devil's brace because it's an awful, awful device. It's hot, it doesn't work well, patients hate them, they're hard to wear. They are, if you have a strong enough patient, they can overpower them most of the time, which is a problem. So you'll have patients that come in and our ortho surgeons will see them and they'll have a 10, 20 degree contracture because they were in the knee immobilizer, but they could bend enough in it that they kept their knee at that slightly bent all the time versus actually locked out in extension. And now you have to work through that before you can even get into surgery, or you have to go to rehab before you can have surgery, and those things happen. So though knee immobilizers exist, and if that's the only thing you have access to, it's better than nothing. But understand if you're expecting something that needs to go to ortho or actually needs range of motion control, go straight to a T-scope. The other big reason for this is, I'm sure as we all know, insurance is awful. And it's getting worse and worse to get coverage for any medical care. Bracing is getting significantly more strict on coverage as well. Most CMS, Medicare is always the most stringent. However, everybody is starting to follow them. So whatever rules Medicare has, everyone else is starting to follow. So the problem is if you put somebody in that knee immobilizer, which is relatively inexpensive, and it's a good reason why ER stock them and things like that, they might not be covered now for a T-scope. And that brace isn't cheap. It doesn't come cheap. And so you run into a lot of insurance barriers. So I always say in the initial, it's always a little bit better to overbrace than underbrace just because if that's the only thing they're going to have covered, I'd rather have them have a T-scope that has controllability, that you can adjust range of motion, that's breathable, that's more easy to wear, that you can fit multiple legs. Have that versus something else. So just remember that as well, that insurance is getting very tough, especially with knee bracing. So just be careful how you prescribe because it could change what they have covered in the future. But so they have that T-scope. You control your range of motions. For patients that maybe have more of a chronic, I see this a lot in the elderly patients. They can't tolerate a T-scope. It's too big. It's a little too heavy. There are wraparound type braces that have a T-scope hinge to them now. So you can still lock a patient out. It's not as good as a T-scope as far as controlling, but if it's the only thing your patient can tolerate, or if you have a tiny patient, they work really, really well, and it allows you to progress that range of motion. For OA, I could talk an entire presentation on unloader bracing. Long story short, are they effective and can they help? Yes. Are they good for everyone? No. They're kind of like KT tape. When it's used appropriately, it actually has a real use. Is it overused and not usually used appropriately? Probably more times than you would think. So, few things to know about OA bracing. One, they have to have mobility in their knee. And what I mean by that is on a varus or valgus stress test, if that knee doesn't move at all because the arthritis is so bad, a brace isn't going to help that. So they don't have the ability to offload a joint because that joint's not going anywhere. So that's number one for any osteoarthritis bracing. The second is compliance usually. Can you get them to wear it and how effective can that be? So for unloader bracing, they do have double upright and single upright. What I tell most of my patients, for a single upright, it's for smaller patients. So if you don't weigh a lot, we have a population in San Francisco of a lot of women that are 5 foot and 100 pounds. You don't need robust on them. Small works just fine because the amount of force you need to correct isn't that bad. Number two is their activity level. If you're playing basketball, you will overpower any single upright unloader. The impact is too much. You have to be in a double upright to get actual control and unloading. So that's how I kind of talk to my patients when they're like, well, can I have something smaller? No. Can I have something softer? Also no. A blanket doesn't control you as well as a straitjacket, right? You need that hold to actually create correction and do those things. So unloader bracing is probably the thing everybody sees the most. Like I said, it can be helpful. And it's usually helpful in two ways. One, patients that can't have surgery right now, right? Knee replacements take recovery. People might not be able to take work off, or it's the holidays, or it's just not right for them financially. There's a whole bunch of reasons why surgery might not work right now. This can be a temporary Band-Aid to get them through their day, allow them to be ambulatory, get them back to some activity to get healthier maybe for surgery, things like that. The other patients are the ones that never want surgery. If that's the case, then yeah, let's give it a try and see if we can reduce pain for that person. If they're never gonna go under the knife to correct it, let's see how much pain reduction we can give them. So that's kind of how I approach OA bracing. It can be medial or lateral. There's a lot of options on it. There's custom and off the shelf. So it's there. It's like I said, I could talk forever about it, but those are kind of my pearls on OA bracing. And then for patellofemoral, again, probably the second most common thing people are seeing out there. It's a mixed bag. Can it help? Sure. Is it a cure? No. And that's why we do this, I always say, in conjunction with rehab, because if you don't get stronger, I don't care what brace I put on you, it's only going to last so long. You have to do other things to get better. One thing that Dr. Sender talked about earlier with McConnell taping, that's a great first step. Have them McConnell tape. See if it's effective in any way. If they're getting at least some relief from it, patellofemoral bracing may work in that short term to allow them to progress in PT, to do longer walks, around the block or something like that. Again, not the cure, but at least it likely has an effect to it. There's a lot of studies that are starting to happen, though, with patellofemoral bracing on knee extension assist braces. So that's kind of the new wave of patellofemoral bracing, where we're not actually focusing on holding the patella, controlling it, and not letting it go all the which ways. It's actually giving it extension assist so that quad tendon doesn't pull as hard and doesn't create as much shear force. Therefore, it reduces pain and swelling and those types of things. There's a couple brands that are starting to make these braces. There's a couple of our doctors that love it, that we've been putting it on patients. It's relatively effective. It's actually been working really well. However, it is a Band-Aid, so your patients still need to go to PT. They still need to get stronger. They still need to make gait corrections and deficiency corrections. The brace is only going to help for so long, and it's just your Band-Aid. So that's kind of the new wave of patellofemoral bracing, is actually extension assist style bracing. And then the other places that I use these are Ehlers-Danlos. It's a diagnosis that we see relatively often. I'm sure a lot of people don't, but the university sees everything, so I see it quite a bit. That's one where bracing likely is a long-term answer, because they're always going to have this. They're always going to have this joint laxity. And so long-term bracing tends to help, like I had a girl once that wanted to fish with her dad. That was her only thing she wanted to do. So we put her in double ACL functional braces so that she could brace her feet against the boat without her patellas dislocating from any excessive quick motions or MCL, LCL tears. And so we put her in double upright so her feet could support. And then we're not talking about wrist today, but we put her in bilateral exos to immobilize the wrist so that her wrist wouldn't sublux over and over when she would try to pull the rod back. For her, no surgery is going to solve her problem. PT can help, but again, she's always going to have issues. So for her, bracing was a long-term answer, and it works fantastic for that kind of stuff. So again, know your patient, know why you're bracing, and understand how that can affect them.
Hey, Tim, what's more expensive? Valet parking at the Hyatt or a medial unloader brace?
Long-term, definitely Hyatt parking.
Yeah, that's what I thought, yeah. All right, cool. So let's talk a little bit about rehab with bracing. So Tim did a good job of kind of talking about how PT can play into this. So when we talk about it again, I'm going to break it into post-operative and non-operative. And what I'll tell you is that from a PT standpoint, we see a spectrum of post-operative protocols in terms of bracing, right? We could talk about ACL specifically. There's not good research on T-scopes after ACLs. We still see it 95% of the time, right? Most of the research does not support T-scope use after an ACL. It doesn't hurt, it doesn't help, but they're still used. So we'll talk a little bit about why that's important and where kind of I think that they're helpful. Who knows who's the first picture here overlapping my with word? Somebody's got it. No. Tom Brady. Good. All right. TB12 is on his number. It's easy. And then how about the bottom? Who's the bottom? Yeah. RG3. RG3 because he's had like 3 ACL tears. In one game, right, with a brace on. So post-operatively, we use that brace again to understand the range of motions for the protocol. Same thing as the hip, right? Generally, we're going to see more knee-based range of motion deficits in kind of more advanced knee surgeries. So things like Fulkerson osteotomies, where we have limited range of motion, quad repairs, where we have limited range of motion. It's really helpful in those kind of situations, right? We can maintain a locked extension position with weight bearing in some of these. These are important for things like meniscus repairs, where we don't want that loaded shear through the knee. Quad tendon repairs, again, which are like my worst nightmare, because if they start to bend a little bit early on, it starts to stretch and it's really hard to bring it back, okay? We also generally see quad tendon tears in older individuals who aren't as active, right? The quality's not as good. And so these are really difficult. And this is one place where I really do like braces, because it really forces those patients to slow down, stay straight, limit their range of motion, because we see big problems with this. You can perform exercises out of the brace a lot of times with guidance. So, if I'm with them in the clinic, I'm going to be watching that range of motion. An example I use a lot with our residents is meniscus repairs. So when we have meniscus repairs, most of our protocols at UCSF are limited to 0 to 90 degrees of flexion. I'm not going to sit there and keep measuring that degree of range as they go through. And most of these patients, when they get to that 6-week mark and they can pass 90 degrees, they're already going to be at 100, 110, 115 degrees. It's really common. What we want to really use that brace for is when they're at home, not going past that 90, not pushing beyond that range. I can make sure they're not pushing when they're in front of me, but I can't do that when they're at home. So it gives them that guidance, and it reduces that fear of, am I going past 90? Am I going to damage this repair? Am I going to create problems? So it really improves their confidence when they're doing their exercises at home. Improving their confidence improves consistency, right? It's the biggest thing that we struggle with in PT is keeping patients consistent with their exercises. There's 700 memes online of my patient not doing their home exercise program, right? The biggest thing that we can do as rehab providers is make sure that we're doing everything we can to make them more consistent, because generally it's something we're not doing right that's causing them to be inconsistent. Not always, but most of the time. Non-operatively, we use these braces for exercise efficiency, so reducing pain. So Tim talked a lot about patellofemoral pain, right? It's probably 60% of the stuff that we see in knees these days. So if a brace is helpful at reducing that pain, whether it's a tracking issue or just a chondral issue, whatever the cause is, if a brace can reduce pain and I can improve the efficiency of their exercises, now I can start to get some of that muscle activity going, right? One of the exercises we love in rehab, most of us, is knee extensions. I love doing knee extensions because I want to get those quads isolated. I want to get them stronger. Getting quads stronger helps to unload the joints. It helps to unload that patellofemoral joint if my quad works better. When I'm going downstairs, if I can control that eccentric load, Then it's not putting as much of that forward shift into my knee and that load through the patellofemoral joint. If I can't do that, though, just with them at rest, but a brace can give me a little bit more tolerance to that, boom, let's go. Throw a brace on it, let's make it happen, right? I'm not trying to improve their tracking right now. I'm just trying to improve their pain so I can improve that exercise efficiency, right? Same thing when they start to return to activity. If someone wears a brace and they can run for 10 minutes with 2 out of 10 pain and they don't wear a brace and it's a 7, why not wear the brace, right? Let's go running. Let's get them active. So that's really where these braces are going to come in handy. We can modify the range of motion. We can gradually wean from them over time, and that's the goal. We're always trying to gradually wean out of these braces so they don't have to become dependent on it, right? Some of them we can wean a little bit faster. Some of them we can wean a little bit slower. Some of them have comorbidities where we may not be weaning from it. They may use it for the rest of their life, but it shouldn't impact their ability to progress, okay? Sometimes even a simple sleeve is more effective than some of these fancy braces that cost more than the valet parking, right? So more often than not these days, for a lot of knee issues, I'm telling people to just try a sleeve first. And what you're getting from the sleeve is similar to what Carlin was talking about with the taping, right? Like, how does it work? Majority of the stuff that we talk about with kinesio tape, the elastic taping, which works great for patellofemoral pain, or these sleeves is proprioception, right? And what you'll hear from every patient that you tape their patellofemoral joint with kinesio tape or rock tape or whatever brand you want, or put a sleeve on their knee, is it feels more stable. That just feels better, right? And that's that ability of your brain to understand that awareness of your knee. Where is it at in space? What's happening with it right now? And that proprioceptive improvement is what's improving their overall confidence. Your brain's alarm system's coming down, right? It's like, I feel more confident with this thing on. A sleeve doesn't affect you in a negative way at all, other than it's hot and maybe you get a reaction from the neoprene, right? So sometimes these sleeves are just as effective, if not more, than the $750 unloader braces. So something to keep in mind, both from a clinical standpoint and a rehab standpoint. Tim and I decided to throw a fun picture in for you of the complex cases we like to see at UCSF. So this top, for you guys, right picture. What do you guys see in this picture? What stands out to you in this picture? Somebody raise their hand and throw it out there. What's that? Yeah. There is an elevated portion of the tibial prosthesis. That is correct. This was a revision TKA, so you guys know history. Had a TKA with an extensor tear, and it got infected. Had to be redone after the antibiotic spacers were taken out. But what stands out to you? Why was this patient having a lot of pain standing up? The patella. Where is the patella? Sitting on the implant. Yeah. So he came in and he said, it feels like my patella is getting grinded down by my knee implant. And I said, yeah, that's what it looks like. So I can't even tell you that that's wrong, right? Sometimes we're like, oh, my shoulder's grinding in place. You're like, that's not a thing. That's a thing right there. That's about as thing as you can get. So Tim talked about changes that we're making in patellofemoral bracing. Is a basic patellofemoral stabilization brace going to work for this? No, right?
KT tape will.
KT tape will definitely work for that. Yeah, 100%. Also a cup, suction cups.
Yeah.
I'm going to pull it up. One of the pain management doctors thought we could use magnets. That was cool. But the biggest thing here is we had to come up with an idea of how we could get him more comfortable in this knee. Because what I didn't tell you is that on his contralateral side, he's a hip disarticulation, right? An ambulatory hip disarticulation. So he has a prosthetic and he's learning to use it. But sit to stand, bending, walking more than 30 degrees of flexion, stairs, impossible. He had so much pain it would give out, right? The last thing I want when I'm trying to walk with my hip disarticulation patient is for his opposite knee to give out, right? That's my worst scenario. So one of the things we came up with was a knee extension assist brace, right? It's about the only thing that we have that can help him take some of the load off that patellofemoral joint. So this is one that we're trying with him to see, can we get a little bit better improvement in that pain, a little bit more function out of that knee, give him a little bit of help there since he can't tolerate strengthening the quads very much, right? And see if we can get some improvement. So this is where our brace can be really helpful in the rehab setting. Does that make sense?
And then just some take-home points, and then we'll go to questions. So again, bracing normally used in conjunction with physical therapy. It's a really big thing. You shouldn't use it as your cure. You should use it as your Band-Aid to help your cure. It does not make you weak. The one exception I will say is people that wear ankle braces 24/7. That's actually a bad thing. That one will actually atrophy your ankle. If you aren't doing exercises in between and or doing things outside of that brace, you will get a weaker ankle. Outside of the ankle, none of them truly are going to make you weak because they don't supplement the muscle, they support the muscle. So those muscles still have to fire in a knee brace. Those muscles still have to fire in a hip brace. And so that's why it doesn't make you weaker. The other thing is it can be used for protection, whether it's range of motion or we talked about prophylactic. When you see a lot of those football players wearing knee braces, especially you'll see linemen, right? Every lineman in the NFL has a double upright ACL functional brace on. Most of them have not torn their ACL. It's actually one thing I tell every patient, a brace does not prevent injury. You can still get hurt in a brace. It can reduce the severity of the injury, and it can reduce the overall risk of that re-injury, but it can't prevent it. So those linemen are actually wearing it for when all their 300-pound linemen fall on their leg. You're hoping the brace takes the brunt of that force so that they don't completely rupture their MCL, so that they don't completely rupture their LCL. It's not to stop an injury altogether. It's actually to just reduce the severity of it. And then, you should never use your brace to supplement PT. If you're not getting stronger, things are never going to fully get better. And so that's one thing I always push home to every patient. You still got to do your home exercise program. I know you feel great in the brace, but go do those things in the brace then. Don't just wear the brace so that you don't have to do them anymore.
All right, let's go through a couple cases here. We'll throw some questions to you guys first, and then you can throw questions at us. So we have a 60-year-old male patient with complaints of right groin pain, which has worsened over the last few years. X-rays show KL4, or severe, right hip OA with subchondral cysts. His aggravators are prolonged walking, cold weather, sitting on a low, soft surface, getting in and out of the car, or pivoting over his right leg. He feels better when he's lying down, using heat, using NSAIDs, or moving for short durations. He's done a few rounds of PT with some improvement, but he still struggles with positional tasks. He's planning for a THA in 3 months due to availability. The surgeon had to go out of town. So some questions for you guys. What would we focus on in rehab for this? So one of the PTs in the room, why don't you guys give me one focus area? It doesn't have to be a specific exercise, but one focus area you would want to do. Increase anterior hip flexibility. Good? Okay. One other thing. I'm going to start calling on the PTs in the back that I know.
We know there's more here. You raised your hand.
Can't get away from us. Glute strengthening. That's always a good answer, right? Glute med. It's always glute med. Jaw hurts, glute med. Why not? So good. So we've got some flexibility, control, extensibility. We've got some stability. I like it. Good. What bracing could assist with this rehab? Tim talked about one. Tim, what bracing could help with this rehab?
So there's that one that looks like biker shorts that pulls that hip into external rotation and tries to reduce some of the stress on the hip. Now, it may or may not. That's one of those things. You don't know till you try, but that could get that patient to that 3-month mark and make it tolerable to get to that 3-month mark prior to surgery.
How long would they wear that brace for?
Till they went to surgery.
There it is. Could biker shorts work just as well?
It might. It's similar to like a knee sleeve, right?
Yeah,
Compression and proprioception can help. So you could tell them, you could try when you're going to go for your walk, wear something a little bit more compressive. Now, we don't want them in biker shorts all day. It's not good for a lot of things. But if you're trying to exercise and stay healthy prior to that surgery, right, the less, like Dr. Steiner talked about earlier, the less you weigh, 5% makes a big difference, right? So if they're trying to lose weight prior to that surgery or not gain weight prior to that surgery, and you're trying to keep them active, it absolutely could help. Case 2, 35-year-old female patient. She's status post left ACL. Tear was 3 weeks ago. Got in right away. Happened to know a good doctor. They were, next door neighbors. They watch each other's kids, so they got in right away. They're 1 week post-op from their isolated ACL with a hamstring autograft. Difficulty with full quad activation, not uncommon to have happen. They got a 10-degree quad lag, moderate effusion still. Obviously very fearful, they're guarded, and then they're using their bilateral axillary crutches with a pain 3 out of 10. T-scope brace, yay or nay, PTs? Or anyone?
Who says yes? Raise your hand if you want a T-scope on this patient. See a couple, few. Steph raised her hand, she wants one. Who doesn't want a T-scope on this patient? Nobody wants to raise their hand because they're like, nah, there's surgeons in here, I don't want to talk about it, right? Okay.
So why would you possibly keep them in that brace?
Yeah, so the most important thing to me on this exam is their quad lag, right? And so for me, if they're having a hard time with quad activation, and there's no meniscus repair here, so we're weight bearing, and we're walking, and we're doing stairs, that quad's not going to work as effectively as I'd like, and it's going to fatigue really fast. And that, for me, is a fall risk and a re-injury risk, right? I treated a patient about 8 years ago that had an ACL surgery, was doing rehab. Her PT cleared her from the brace after about a week and a half, and she fell down the stairs, and she fractured her patella. And she was 16, played high school soccer, and was trying to go to college, right? So she ended up with a patellar ORIF, and now she's got patellar ORIF hardware on top of an ACL reconstruction that we're trying to rehab, and then they sent her to me. And so that's my worst nightmare with this type of quad lag, is that they're going to fall and create bigger issues, right? So in this situation, I do want that brace because it's going to give me a backup situation. If that person starts to get some quad fatigue and they start to have that knee giving out, I know that brace is going to be there to at least give some backup support until they can catch, right? And it's going to prevent bigger hyper knee flexion issues that could create some issues, or valgus collapse that's significant, right? Is it going to prevent it? No. Is it going to reduce the risk? Yes. So for me, when I see that quad lag, when I see that inability to really effectively use that quad, now I do want that brace still. All right. If we're going to brace it, which one are we going to use? Are we going to use the long one, or are we going to use the short one?
Yeah, for this year in the long. You need full control. You need lever arms to hold that in full extension. Plus, even in that scenario with the 16-year-old, how many 16-year-olds just sit around? 16-year-old athletes that have aspirations of playing college athletics. They're going to fatigue that muscle at school. And so though you want them to continue using range of motion, you can't trust them to do that when they're standing, and be smart. So what do? You say, hey, you're locked in extension when you're standing. When you're weight bearing, I want you locked. Why? Because I don't trust you when you're at school. When you're here with me, we'll do other things. When you're there, you're locked. But when they sit at their desk, when they go home, when they're doing their homework, they can unlock and continue to work that range of motion. But you need that true control, and you're only going to get that from a long T-scope.
Now, in terms of rehab focus, we talked a little bit about that quad. So one of the things that I see a lot is that when you have a quad lag and straight leg raise, they're just using straight leg raise to try to get straight leg raise better, even though it's an ineffective straight leg raise, right? So outside of straight leg raises, we need to be utilizing more quad-specific activities with these patients. Everyone's afraid of knee extension, but it's a great exercise for this patient. If I can put them at the edge of the table and really get them using that quad, I can even assist it a little bit with the other leg to start, right? Use that quad in isolation. Keep the hip flexor out of it. Focus on the quads. Now I'm going to start to get better quad activation, better quad control. Hopefully over time with a little less effusion, I might get a little less of that swelling inhibition. And now I'm going to start to get more of that function with that knee extension hold, right? But just using straight leg raise that's ineffective to make straight leg raise better, to me, it just doesn't make sense. So we've got to stop doing that, okay? Other rehab focus, right? We want to continue to work on gait function, control, making sure with that gait we're getting that good heel contact, that terminal knee extension, right? And then always glute med, because why not, right? So big focus on that quad though, isolated quad.
Questions? I don't have one. A brand that I know that does it well, you can Google them, is Icarus, Icarus. It's not a promotion for them. It's just they're one of the few that makes the brace. It's not a brace that's commercially found. And so they make them. And essentially what they did is they took a spring system throughout the brace that they weave in their 3D printing, and then there's a dial attached to it for like a boa that you can adjust the tension. So you can actually turn the tension so high it locks them in extension, like you wouldn't be able to overpower the brace, but you can also control how much extension assist you get. So for like the other patient over here doesn't have a sound side to push off of, you can crank that extension up and allow them to really get a push and then turn it down so that they can then just have a mild extension assist.
T-scopes, how do you adjust for people's weight?
Most of them go up to 300 pounds of like allowable force on there. They do make XL ones that are even more robust. And then if you really need it, for us, we'd go custom if we really had to. And we'll build a custom device with stainless steel bars and stuff like that if we really needed to. It's pretty rare that you need that. We do bariatric. There's a bariatric population has a quad tendon issue. I'm sure you see that in your rehab where they rupture their quad tendons a lot. So we have to put these on when they do the quad tendon repairs, relatively heavy people, and most brands are going to hold up pretty strong to that.
In my urgent care, we have a standard brace, and then we have the short T-scope brace. We don't have anything long, and I always look at that and I look at the patient and is that really going to do anything? But you're saying if I put them in a knee immobilizer, then maybe their insurer won't pay for a better brace later. So how would you make that decision when somebody's kind of blown out their knee? I did an X-ray. They need to see orthopedic. I don't know what it is.
Then I'm throwing them in a T-scope. I'm throwing them in the...
Even the short one.
Oh, so the question was, they work in the ER. They have limited brace options there. If they only have a short T-scope available versus a knee immobilizer, but you're worried about insurance covering another brace, what do you do? I'm going to err on the side of safety versus cost at that point. They may not want to cover a second brace, and there's other options. You can buy things online. You can do things like that, but I'm going to err on the side of caution and make sure I can lock them out safely so that they don't get that 20-degree contracture while they wait to go see ortho. That's what I'm going to do. There's one in the back. I want to give, somebody had their hand up in the back. Yeah.
Thank you. Two questions. First is there a contraindication to use the extension assist brace if there's a pre-existing recurvatum or if they're on that hypertension spectrum? And the second question is, do the trochanteric belts work for that 6-year-old patient that was waiting for the total replacement? Does that do anything? Does it do what the biker shorts do symptomatically?
So two questions. One, is there a contraindication to the extension or contraindication to, the extension assist? And then for the hip, does that BOA, is that going to help to get them to that next level? The BOA, I'll go with the hip first. It's hit or miss. It really is. It's kind of like some injections. For some patients, they work great. For some, they don't do anything. But if they can't have surgery and they need to be mobile, it's worth a try. You know, I would at least give it the effort. For the extension assist, there's no real contraindication because you can have them fully custom made. So I have patients that have a huge recurvatum or genuvalgum or varus. That's when we go custom. If their knee doesn't fit off the shelf, you can go fully custom with those.
Yeah, and the adjustability of it is nice because it allows us, even in rehab, to kind of watch what they're doing. And if they're every time coming up and starting to try to hyperextend, then we can make that adjustment. So it's easy to kind of monitor and adjust just with a dial, which is what's nice about it. We don't have to send them back and have, orthotics do all these adjustments to it. It's easy for us to just dial down the resistance a bit.
A couple questions on the app. My patients buy all sorts of braces over the counter. Are any of them in the under $100 range any good? And which one should I buy? Reliable brands. There's a couple DME companies that are here in the areas over there. Go see them, talk to them. We're not going to have people come in that we don't trust. So there's some good brands here. Go talk to them, see if they have some options on that. But as far as under $100 for the knee, no, in all honesty. Most of the ones that you're going to find online for under $100 are not going to give you support, especially if you're looking for like ACL or assist. they're just not, the quality is not going to match what you need it to do. An ankle brace, an ASO, absolutely. A wrist splint, totally. But not for a knee brace or a hip brace. Those are going to be more expensive than $100. But yeah, go talk to the brands in the back. I'm sure they'd love to tell you.
The only thing I would add to that is the sleeves, right? 'Cause
Sleeves, yes.
Sleeves, there is a difference in the sleeves. You can do the Amazon sleeves and the neoprene sleeves. A lot of people react to the neoprene. They don't love it. So some of the more fabric-based sleeves, things like Incrediwear or Bauerfeind, are really nice sleeves. They're more expensive. They're still under $100. They're still cheaper than parking. Certain Bauerfeinds, yeah. But those are the ones that I tend to have people get if they have a reaction to the neoprene, because they're a little bit nicer and they tend to stay up a little bit more. It's one of the issues with the sleeves is if you have quads, it slides down, so they'll tend to stay up a little bit better.
What about copper? Patients always ask me about copper.
It's great for electrical. It gets stolen a lot.
Yeah, it can be sold on the black market.
Yeah, you can make a lot of money on it. You should try selling those sleeves. I wonder if you could sell it. No, I mean, from a research standpoint, there's zero benefit to it. It has not shown any sort of change. I can tell you anecdotally, I've had patients that have come in with copper and it hasn't made any difference compared to the non-copper ones. So that's one of those infomercials I get mad at night. But outside of that, I haven't seen any difference.
As a sleeve, if it works for your patient, great. It's not, their claims are not scientifically backed. Next question. This one actually has to do with an ankle. We're going to talk about this tomorrow, but I'll do a very quick response to it. I always warn my athletes that taping, bracing their ankle may increase their risk of injury, stress to their knee due to the decreased mobility in the ankle referred proximally. Does bracing the knee cause the same risk, stress to the ankle? From the ankle to the knee, most braces aren't rigid enough to really make that difference. You are overpowering most ASOs. Now, not that they don't help. Again, they can reduce injury, but they're not reducing mobility to a point that you're going to hurt the knee, in my opinion. And then vice versa, or the other way to the knee, to the ankle. Most of the time, when we brace for the knee, we're putting them in a better gait cycle, and we're putting them in a more controlled, pain-reduced gait cycle. So those stride lengths tend to be longer and more accurate. They tend to be better, more repeatable. And so actually, I tend to find other body parts hurt less when you help the knee. So hips and ankles tend to feel a lot better when you're addressing the knee.
Yeah, I would agree. I don't think we see that down chain mechanism as much as we maybe see some up chain mechanism. Again, if you really lock that ankle down, sure, you're going to find another pivot point, but not the same thing with the knee. I totally agree. You're going to usually get improvement, not worsening or increased risk.
And then last one, T-scope case number 2. Would it be better to keep them in crutches, weight bearing is tolerated for quad activation, and encourage use versus using the brace? I'll let you start with that.
Yeah, so I mean, we're talking about case 2. So when we talk about this, the question was keeping them in locked extension, I think was the question. I don't really want to keep this person in locked extension. I would keep them on crutches, but I would still be weight bearing as tolerated. There's no reason to not weight bear. We want to get some load through that leg. The best way to get muscles working is to put load through them, right? So I don't want to make them non-weight bearing, but I do want to make sure I limit the amount of range of motion that comes from that brace in case it does give out. And I want to make sure that I'm giving them exercises that are promoting that load safely. So that's the biggest thing. So no, not weight bearing limited and not locked in full extension. I want them to learn how to use that 0 to 30 range. But I am going to keep them on crutches just to be a little bit extra safe for a little bit longer before I wean them off those crutches.
Any other questions? Yeah.
You know, I see mostly osteoarthritis, degenerative disease, and or patellofemoral. Now, these people show up with these sleeves. Are you telling me the sleeve is good for patellofemoral?
Yeah, so the question was, he sees a lot of patellofemoral and osteoarthritis in the knee. People show up with sleeves. Are the sleeves really that great for patellofemoral joint? And I would say, I think the sleeve is enough of a brace with patellofemoral pain, yes.
But aren't you putting pressure on the patella?
Yeah, it's a good question. So is the compression enough to cause some issues? Sometimes. If it's a really sensitive patellofemoral joint, occasionally you'll see increased irritability in that sleeve, but you'll know right away. So I tend to find that the proprioceptive changes with patellofemoral pain are more important than the compressive force in a locked extension position. They're usually going to have pain with knee flexion at a certain angle, no matter if you have a sleeve on or not, because you're going to get so much compression through there. Those sleeves do stretch over time as well. So when they're new, they're a little bit more restrictive. They will actually limit range of motion early on, which sometimes is better because they don't get into those painful ranges. Most people with patellofemoral pain don't have pain with standing straight. They have pain with a slightly flexed position and load through that slightly flexed position. So that's usually where I'm going to see the most issues. So long answer to your short question, I think the sleeves are more beneficial than not. Sure, occasionally you might see a high sensitivity patient, but it's also going to control swelling if there's any swelling in there. So I like the sleeves a lot for patellofemoral pain. I think they're enough.
And there is a such thing as a placebo effect. Yeah. Thinking you feel better, a lot of people feel better. There are plenty of braces I put on somebody that I'm like, this isn't really solving your problem, but you put that brace on and they start dancing like Charlie in the Chocolate Factory when the grandpa gets the golden ticket, right? They're out of that bed and they're doing jigs. It sometimes that is what you need. And so is it curing anything? No. Is it truly supporting the knee joint? No. But do they feel better? That's a real effect. If that gets them out moving more, progressing more, being healthier, totally worth it. Worth $30.
You're on point with your analogies today. This is solid. I'm stealing the straitjacket one for sure. How are we doing on time, Carla? Any more questions?
And we'll be back tomorrow. Feel free to ask anything between now and then or tomorrow.
All right, thanks, guys.